Hi, welcome to this first session in this course on cluster randomized designs in cancer care delivery research. So in this first session, I'm going to provide an overview and an introduction into the parallel cluster randomized design. So here are a few acronyms that we're going to use throughout this session. They're just here for your reference. So what I want to do in this session is to introduce the cluster randomized trial, think about some of its key features, and then go on to outline some of the key ways that cluster randomized trials differ to patient randomized trials. And so to this end, I'm going to think about what the unit of the intervention is at the level of the individual, the cluster level, or the professional level. Think about participant recruitment, and then think about different types of outcome types, including process outcomes, mediating outcomes, and clinical outcomes. So before we start, a little bit of terminology. In the US and some other parts of the world, this type of design is referred to as a group randomized trial. In Europe, Canada, and Australia, it's referred to as a cluster randomized trial using the acronym CRT. And in this course, we're going to use the terminology cluster randomized trial and use the acronym CRT. So first of all, how does a cluster randomized trial differ to a conventional trial? So in an individually randomized trial, we might refer to these as a patient randomized trial. Patients are allocated to different interventions, and we refer to these as treatment or control conditions. But rather than randomize individual patients, cluster randomized trials randomize entire clusters. So some examples of clusters include things such as wards or clinics, hospitals, primary care practices. Clusters like this are typically used in a healthcare setting, but also these designs are used in a non-healthcare setting, and in non-healthcare settings, typical clusters might be, for example, schools or social groups. So in a patient randomized trial, we take our individual patients and then we randomize each individual to the intervention or the control condition, here depicted by a drug. But patient randomized trials don't necessarily always randomize drug or test drug interventions, but they often and typically can do. In a cluster randomized trial, on the other hand, entire groups of patients or participants are randomized to intervention or control condition. Now here, the intervention and control condition are not depicted by a drug because many cluster trials are not used to evaluate our typical pharmaceutical interventions, but they might be used to evaluate something like a behavior change type of intervention. So I'm going to use this schematic representation throughout the course to describe the trial design. Now, sometimes the colours might vary when these schematic representations are taken directly from other studies, but typically we'll use the light shaded colour to denote the control condition and the darker shaded colour to denote the intervention condition. So in this example here, we've got 20 clusters. The first 10 clusters are randomly allocated to the control condition, and the second 10 clusters have been randomly allocated to the intervention condition. Now, one thing to note in this representation is that the schematic is represented over time, and this longitudinal representation allows time for patient accrual. Now, this will become important when we move on to consider parallel cluster trials where there's something called post-randomization recruitment, and also in what we're terming multiple period designs, and we'll look at these types of designs more in session 1C. So let's move on a little bit and think about the unit of the intervention. I'm going to think about dividing up interventions to being delivered at the individual level, the cluster level, and the professional level. So cluster randomized trials can be used to evaluate different types of interventions. The unit of randomization, which is what we call the cluster, is often different to the target of the intervention. So for example, a cluster level intervention is an intervention that is delivered at the level of the entire cluster. So for example, this might be a change to the electronic healthcare record, for example. A professional level intervention is something that is delivered at the level of the healthcare professional. So one example of an intervention that's delivered at the healthcare professional is something like education. Individual level interventions, on the other hand, are delivered directly to the individual participants, and they may include things such as drug interventions. So over the next few slides, I'm going to illustrate 4 examples of cluster trials where they are evaluating different types of interventions. So in the first example, the evaluation will be of a cluster level intervention. Then we'll look at a trial that is evaluating a professional level intervention, then move on to a trial that's looking at an individual level intervention. And then our final example will be an intervention that has a mixture of different components. And these examples hopefully will illustrate the difference between the cluster, which is the unit of randomization, and the unit of delivery of the intervention. So here's our first example. It's called the Survivor Link study. It's an example of a cluster level intervention. So in this study, the cluster, the unit of randomization, was the pediatric clinic. And the intervention, that is the thing that the investigators were trying to evaluate, was some modification to the electronic healthcare record. And the unit of delivery was a pediatric clinic because the electronic healthcare record was embedded into the health system. So therefore, this is an example of a cluster level intervention. So the unit of delivery and the unit of randomization are the same here. Our second example is what's called the colorectal screen trial, and this is an example of a professional level intervention. So in this trial, the unit of randomization was a medical practice, and the intervention was a method to allow physicians to receive a list of what we're calling non-adherent patients. So these were patients that were not accepting screen invitations. So the unit of delivery is a physician because the physicians were given this list of non-adherent patients. And so the unit or level of the intervention is a professional level. So here we have an example of a cluster trial where the cluster is a medical practice, yet the level of the intervention is the professional level. And our third example is what's known as the CAP trial. This is an example of an individual level intervention. So in this trial, the cluster, the unit of randomization, was a primary care practice, and the intervention was a PSA screen and a standard diagnostic pathway. So the unit of delivery here was the individual because the individuals were given the PSA screen. And so the level of the intervention is the individual. So here another example where the cluster, that is the unit of randomization, and the level of the intervention differ. The cluster here, the unit of randomization, was a primary care practice, but the intervention was targeted at the individual. And our final example is what's known as the rural cancer trial. And this is an example of a study that was evaluating a mixture of interventions targeting different levels. So in this trial, the unit of randomization, that is the cluster, was a whole community. And the intervention was multifaceted. It had a set of community level interventions, and these included things such as cancer symptoms awareness campaigns. And then there were also other components to the intervention that targeted the general practitioner. And these included things such as a resource card with symptom risk assessment charts, etc. So the unit of delivery here was both the community and the general practitioner. And so this therefore means that the intervention is targeting both the cluster, or is delivered at both the cluster level and the professional level. So let's move on again and now think about participant recruitment. So to ensure allocation concealment, there's a recommended process in a patient randomized trial that is almost always followed. So in a patient randomized trial, we recruit individuals, and after those individuals have been recruited, they are randomized. And this specific ordering is almost always followed in patient randomized trials. It's followed because this recruitment ordering allows us to ensure that the trial has proper allocation concealment. Unfortunately, in cluster randomized trials, this ordering is often reversed. So what often happens is the clusters are randomized and then individuals are recruited. This can lead to bias. And we're going to return to the implications of this reversal of the ordering in another section. So let's think through why this can happen. So in a cluster randomized trial, we can typically divide these types of trials up into those that have what we might refer to as pre-randomization recruitment and those which we might refer to as having post-randomization recruitment. So in a trial that has pre-randomization recruitment, all of the participants are recruited before the clusters are randomized. And after all of the participants are recruited, the clusters are then randomized. Now, this type of trial design only works in what we might call a prevalent population. So, for example, participants who are already available and meeting the eligibility criteria, perhaps they have a specific type of cancer, and that forms the eligibility criteria. So those eligible participants can be recruited, and after they have been recruited, the clusters are randomized. However, what happens more commonly is what we term post-randomization recruitment. So participants are recruited continuously throughout the trial. So the clusters are randomized, and after the randomization of the clusters has occurred, participants are then recruited. Now, this type of setup often happens in what we term incident populations. So for example, if the eligibility criteria are participants who require some sort of emergency surgery, those participants who meet the eligibility criteria won't be available before the study starts. They will become eligible and become available as the study progresses. Now, I've put recruitment in inverted commas because actually in cluster randomized trials, we often don't have the sort of typical recruitment of participants that we commonly have in patient randomized trials. So we might have direct individual participant recruitment. So cluster randomized trials can recruit individual participants, much like in a patient randomized trial. But we can also do other things. So one of the things that we can do is sample participants. So cluster trials can take a random sample of participants from clusters, and this might be particularly useful when only a small subset of eligible participants are required from the entire sampling frame, perhaps to assess quality of life outcomes. We can also do something that we term a complete enumeration. So this means that the cluster trial might take a complete enumeration of all those eligible participants in the cluster to elicit outcomes. Now, this is only usually feasible in settings where both the outcomes are routinely available, so for example, mortality, and waiver of consent is appropriate. And we'll come back in section 7 to think about when waiver of consent is appropriate. So cluster randomized trials have these 3 different ways of implementing their recruitment. And finally, let's move on to think about different outcome types. So outcome types for multifaceted interventions can often be broad, and we might often be interested in multiple outcomes, not a single primary outcome. So we might start by eliciting outcomes on implementation. So examples of implementation type outcomes include such things as whether blood pressure was measured, for example, whether medication adherence has been followed. And on these types of outcomes, we typically expect quite large effects. We might then move on to elicit what we might call mediating outcomes. And examples of mediating outcomes include such things as biomarkers, behavior change, symptom improvement, and other types of patient-reported outcomes. And finally, we then might also be interested in typical clinical outcomes, such as cancer survival or mortality. And here we would typically expect to observe smaller effects. Now, it's also important to think about how we might follow up participants for outcome assessments. So it might be the case that outcomes are assessed almost immediately. So for example, mortality immediately after surgery or 30 days after surgery. So we might elicit our outcomes almost immediately. But there might also be a delay in when these outcomes are assessed. So for example, our outcome might be cancer symptoms 1 year after recruitment. So there may be some sort of delay in our assessment of the outcomes. Now, when we represent our parallel cluster design in this longitudinal format, we start to see actually there may be implications in how we assess these outcomes. And this becomes quite important in multiple period designs, which we're going to think about in a couple of sessions. Now, there tends to be a direct parallel between participant recruitment and outcomes. So in settings where waiver of consent is permissible, we tend not to have individual participant recruitment. We might rely on routinely collected data for outcome assessments, but this can only work for a limited set of outcomes, for example, mortality, which are routinely collected. We might, on the other hand, have a trial where we have direct participant recruitment. So we individually recruit our participants. Then we might collect outcomes specifically for research purposes. This allows a wider choice of outcomes. So for example, we might be able to collect patient-reported outcomes and pain scores. So there tends to be a direct alignment between whether or not we recruit participants and the type of outcomes that we collect. So let's go back to our 4 examples. So remember the CAP study. This was an evaluation of a screening invitation, and the main outcome was mortality. And in this trial, there was no individual participant recruitment. In the Survivor Link trial, the intervention was a modification to the e-healthcare record. The main outcome was emergency room attendance, and again, no direct participant recruitment and reliance on routinely collected outcomes. For the colorectal screen study, the intervention was a list of patients at risk provided to the healthcare professional. The main outcome was whether or not that patient participated in their cancer screen invitation, and again, reliance on routinely collected outcome, no direct participant recruitment. And in the rural cancer study, the intervention was multifaceted, targeted both at the community and the general practitioner. The main outcome was time to cancer diagnosis, and this trial did recruit individual participants because it needed information on symptoms from symptoms questionnaires which were not routinely collected. So in our 4 examples, 3 of these did individually recruit participants and 1 didn't. Now in patient randomized trials, typically participants would always be recruited. So these examples illustrate that cluster randomized trials are different to patient randomized trials insofar as they might not always recruit individual participants. So a summary of the key points we've covered here. So cluster randomized trials randomize entire clusters, and these might include such things as schools, wards, hospitals, etc. They can be used to evaluate a range of different intervention types. And these interventions are typically classified into those that target the individual, those that target the cluster, those that target the professional, or those that target a mixture of all 3. Outcomes for evaluation might include process outcomes, mediating outcomes, or clinical outcomes. And finally, CRTs might not always include direct participant recruitment, and this is particularly the case when using routinely collected outcome measures. So here are the references of the 4 studies that I have cited over the slides. And in the next session, we'll be thinking about what are the statistical implications of using cluster randomized designs.